Welcome one in Schema Therapy Made Simple. I'm very excited today to have my Perth colleague, Ozgur Yalcin, here with us. For those of you who have not met Ozgur before, he is a clinical psychologist and he's the director of the Anima Health Network. Before I introduce you further, I'll just say welcome and you can say hi to everyone. Oz.
Well, thanks to Nadine for having me on. I really appreciate it. Hi, everyone. Pleasure to be here, and hopefully this might be of some help to you. And
absolutely. We're going to keep it very clinically relevant today, so I'm sure there's going to be a lot to get out of it. So as well as being the director of Anima, which is a clinical psychology and a neuropsychology practice in Perth that specialises in the assessment, diagnosis and treatment of acute mental health conditions, Oz is also published in the neurosciences and psycho-assessment area, with his PhD focusing on enhancing the assessment of early maladaptive schemas and the development of the YSQ-R. And as you would all know, if you're participating actively in the group, together with Jason Wessel, Oz has created the online version, which is just amazing. So before we go on to talk about that, just tell us a bit about you and how you became a schema therapist.
Well, that journey started when I was in my clinical master's program, actually. We had the good fortune of having Chris Lee as our adult unit coordinator, and obviously he was all about schema. And so, that kind of really whet my appetite. Aside from being an extremely, enriching experience, it was also terrifying because, I remember the exam at the end and we were talking about different schemas and different scenarios and vignettes. I'm like, oh my God, I had to walk outside, take a deep breath, go back inside.
And isn't it amazing from such humble beginnings that you've become really fluent in the language of schema therapy that you can help create this more up-to-date measure? It's just really quite encouraging, I think, for those people earlier in their careers to hear that.
Thanks. Yeah, it's amazing. I think it's called post-traumatic growth.
What doesn't kill you makes you stronger and those sorts of things. Yes. Okay.
Yeah. I mean, my training is actually in psychodynamic psychotherapy, which is what I, was on my registrar. But the thing that I love about schema therapy, it offers a really nice language for people's experience, and it's a really nice collaborative approach as well. So nice little experiential techniques and things like that that are obviously built into the model, which I really love.
And I think that's important for everyone listening to know, is that you're actually using this clinically. It's not just that you've created this measure from a research space. It's really aligned with what you're doing in your practice as well. And I believe that you mentor quite a lot of early career psychs in that practice as well. So it's nice to know that they're coming through and going to have the benefit of your experience with schema therapy.
Oh, thanks. We do work really hard. Actually, everyone here is schema therapy trained and EMDR trained. So
oh, wow.
They just go, they just
sounds like my kind of practice. Okay. So as I mentioned, the YSQ-R online in particular is really amazing. So for people who haven't come across it yet, it's the first time that we've had a measure that can be completed from a tablet or a mobile from a link. And so it creates easy access, and all of the barriers of I didn't have a printer, or I don't have a computer, or I couldn't save it, is gone now. And for me personally, I am getting very high rates of return, which in the past I might have put down to people not wanting to complete the measure or avoiding it. But really it seems like it was an accessibility issue, I think, now that I've had your lovely tool there. So tell me a bit about the YSQ-R, just generally what led to your research group, which I know included Chris Lee and Helen Creer as well, who's a very well-known researcher in Perth. What led you guys to really look at the original YSQ and see if we could make it stronger and better?
That's a really good question. I think you're forgetting one of my other PhD supervisors was Dr Ida Moraes, and actually my master's thesis was to apply a RASH model, which is like a statistical model for assessing the psychometric efficacy of a questionnaire, to the long form. That was my master's thesis. I didn't write it very well because there were so many other things happening. It was basically survival at that time. But it did really get me interested in the YSQ, in schema therapy more specifically, and this new modern test kind of theory domain, which Ada was incredible. Is an incredible woman and incredible clinical supervisor. So, with the support of my supervisors, we really got I really got a good sense of what the questionnaire or the YSQ landscape looked like. It wasn't very good. So, the long form obviously was like way too long, and the short form is garbage. Sorry. So when you look at the short form, it just became more and more evidence that the psychometric component of it was not very good. It was the most commonly used questionnaire, essentially in the world. So, and then like before my first study, only one other study had done any kind of like psychometric assessment on the long form, which was really amazing to me.
Yes.
And in terms of the short form, there was actually no available research papers that show how it was constructed.
Right.
Aside from the fact that, some items correlate together. I'm not going to bore you with all this research stuff.
No, okay, yes. Yeah.
Basically, we needed this because it didn't feel like there was a, clinically sound and psychometrically sound version of this questionnaire. And so, we took a real kind of systematic approach to it.
So it sounded like it was really needed. And then along that journey, you discovered that there are actually different schemas, if that's the right way to, I'm not actually the best with my research language, I have to say, after years of not being in a master's. These other schemas appeared as being necessary to measure, and also you introduce measuring punitiveness as towards self and towards others, which personally I found very helpful. That comes up. So when I was using the short form, it was almost never anything reading there, but when you put the two together, quite often they have one or the other. So that has been a massive improvement. And, I actually have found since using the YSQ-R, because I was using the short form, because like everybody else, it was easy to use. There was an Excel thing that you could email out to people, but I at times wouldn't use it at all because I would never really get anything from it. But I'm finding from using this, I actually get at least some endorsed schemas on there. Not that it's the only part of the assessment. So what I was really wanting to talk with you about today is particularly the fear of losing control schema and the emotional constriction schema, just to get a real rich sense of what are these schemas, how are they going to look in our clients beyond the measure even, because we can all administer the measure and get that. But I think it would really help us, because I know if I don't fully get something, there'll be others out there that don't get it too, to help us really start to, as we do with many of the other schemas, you can kind of feel it in the room, you can see it in the presenting problem. So let's talk some more about that.
Can I just rewind just one step? Just going back to the previous question about the development of the online version.
Yes.
Because I have to obviously thank my colleague, Dr. Jason Weschel, who actually had emailed me and asked if it was okay for him to use a online version that he'd created for himself.
Right.
And that really got me thinking, well, if that's a possible thing, then how would it be for actually the schema community? And so we then got in contact, and he was kind enough to collaborate on that. And he's a very skilled person. He's a psychologist and also a very skilled developer. And so we put this this awesome thing together. And I'm very grateful to him. And if there's any people who actually have other questionnaires or that they need to develop in a similar kind of way, he's the guy. So
he's excellent at that. And I think it's a testament to your generosity too, that you're very open to collaboration, and you really, like, even with me talking about this interview, I just want to get the information out there, which is lovely. And I'm so happy to be able to provide this platform to do that as well. I actually find that the online, I just couldn't believe the first time I got it back and it just bounced back at me. And I was like, sometimes I send it to people and within minutes I'm getting it back. It's, it's extraordinary compared to the old world of doing things.
I've put together a document that I put together for some other colleagues, and it's some instructions on how to use it properly, so I can send you that and you can...
Oh, beautiful. Yes, I would love that. I'm sure everyone would appreciate that too. So let's begin with talking about the fear of losing control schema. So just give us a little bit of a feel for what that is and what sort of clients have it, what sort of problems they have.
So like a fear of losing control schema is really kind of about, my emotions cause damage. Right. And so I guess when it's like this anxious kind of dysregulated presentation is distinct from like a shame, pride-based presentation in the emotional constriction.
Right.
So even though they're both about essentially inhibiting emotions, they are got different underlying mechanisms.
For sure.
So, for these kind of patients, you find that people have, almost like an inhibition or constriction of spontaneous emotions.
Right.
Because basically there's a worry that if it was to come out, that it would cause some kind of harm, or that they may not be able to contain themselves in some way, or they might be ridiculed or punished or judged. I did say harm others. Did I say harm others?
Yes.
There might be a fear of harming others as well. So, when you think about also like fears of overindulging, fear of losing impulses, being too impulsive. So think about things like ADHD, even in the interpersonal domain of ADHD, or people have maybe difficulty inhibiting what they are going to say. They might blurt something out they don't mean, or they might spend impulsively, or they might do something. And this might also be in the context of people fearing that they're going to lose control of anger or aggression or something like that, for example, in PTSD, or fear of harming others, as in like ego dystonic OCD. So people have like these intrusions of harming other people or stabbing somebody, and so there's a real kind of preoccupation with these internal processes to make sure that they kind of keep
So it's interesting, because when I am seeing OCD in my clinic, I for some reason have only really ever had the harm and sexual obsessions since I've left university. In university I did have someone with the germ type thing, and it's very distressing for them. But it's interesting for me to know that might be something that they're doing to manage OCD as well.
Monitoring, you might see that a lot, right? Yeah. People are monitoring what they're going to say because they don't want to say the wrong thing, or they might blurt out the wrong thing.
Yeah. The other group I'm seeing the fear of losing control schema in is people who've come from family violence backgrounds, and I think where so they have seen anger sort of destroy people, and so then they're afraid of. Would that fit with this schema?
Yeah, sure, definitely. It would also fit with emotional constriction too, but like it's more nuanced, you see. So like in this kind of to try and understand what you're saying, Nadine, is that because they've seen such big emotions, there's a real fear that they may perpetrate or do the same. So they would inhibit even what you might consider mild or like adaptive or healthy expressions of emotion. Absolutely.
Okay.
Absolutely. Yeah. But you might also find that that patients who have come from families where there's lots of emotion dysregulation, where there's lots of anxiety or fear about what might happen in the world, things like that, are more likely to have that same kind of propensity to be worried about something bad happening. Yeah.
Okay. Yeah. So it's interesting because you can kind of see that it might sit with vulnerability to harm, and it might sit with insufficient self-control, and it might, like teasing them out.
But they don't. They're very distinct. Right? That's really interesting, right?
Yeah.
But that's not to say that when the final parts of my PhD, I've actually got a considerable amount of research that touches on the hypothesized origins and all of that kind of stuff, which I'm trying to summarize because I actually want to get that out to people that might find that helpful as well.
Okay.
And it's sort of like we're just kind of trying to get an understanding of how this stuff fits with schema theory as well, if that makes sense.
Yes.
As far as the data and as far as everything else goes, they are very distinct constructs from each other, and it's likely.
Well, that's really interesting in itself, isn't it? Because I think sometimes if you weren't running the measure, you would see it going into other things like the ones I mentioned before. Okay, so and the emotional constriction one, tell us a bit about that one.
The way that I kind of conceptualize that is, my emotions are shameful, and you might have more of a disconnection or excessive inhibition of like sort of any kind of emotional expression, whether they're negative or positive. I hate that actually.
Yeah, I know what you mean though.
I usually go with pleasant or unpleasant emotions, right? So
things that are pleasant, things that are difficult to tolerate and not.
Yeah, sure. We're talking about like anger, aggression, sadness, and also joy, sexual excitement, playfulness. And so, you got a real problem with not only experiencing the almost emotional numbing, and also the difficulty being able to express those because of, I guess, this disconnection from from the emotions.
Mm-hmm.
So kind of like in alexithymia, for example.
Yes, I was just thinking that. So it could look like a body shutdown, and those people who say, I don't feel it in my body,
Definitely.
I don't know what you're talking about. Yeah. Okay.
Yeah. But also you might see this kind of stuff in cultures who value, the suppression of, of emotions. So, like collectivist countries, for example, they value, there's pride in being a rational person.
Yes.
People who value stoicism and cultures that value stoicism, being emotional constricted is actually not the worst thing, right? That's kind of like culturally appropriate. And so those things are important to consider, I think, as well.
Yes. And so then it's still a schema, even though it's culturally prescribed.
Well, it depends on which culture. Right? So for a Western culture, it's much more relevant. I guess this also came to mind. So if you've got somebody from a collectivist country, for example, that has grown up in a family, system, but in Australia, they're going to have strong cultural connections and family dynamics, but also a foot in Western ideology, which is, growing up in schools and in an Australian culture, for example, and sometimes that conflict can cause problems. So then you might say, well, culturally this might be appropriate, but actually I'm feeling all of these things, and so I want to feel them. I'm finding it hard to connect with people, but when I go home, that's normal.
Yes.
Does that make sense?
Yes, absolutely. I had Danny Ho-Tan on recently, and who works a lot with diaspora clients from Asian cultures, and that's quite a common situation that she's working through with them. So I think there's a lot of stuff heading in the same direction in the schema world, just about opening up all of that stuff and really looking at how we can help clients find what's adaptive for them, which is quite challenging across cultures and things like that. So with emotional constriction, what sort of presenting problems might people be coming to therapy with? Is it more the depression or
emotional constriction?
Yeah.
So patients with emotional constriction, you're more likely to see sort of like personality traits of like perfectionism, anhedonia, alexithymia, depression, like avoidant PD.
Yes.
And so in contrast, a fear of losing control diagnostically, they're kind of like more connected to disorders where symptoms, almost like take a life of their own. So things like panic disorder or
there's a lot of energy in the body and
or violent, like the sexual based like OCD, addiction, PTSD, ADHD, social anxiety.
Yes. So it's got more the anxiety flavor on the other side, and there's kind of this fear and bubbling energy. And on this side, we've got the shut down body, and I can't feel anything, and I'm not connected to people.
So in the room, like an emotionally constricted person, they present, they might have like, like still face, they're pan faced, they're unemotional, and they're very difficult to connect with. And so that's not by accident. That's because of, the origins have made it so that, would have shaped their way of being in the world. And so, maybe even in the transference, it's difficult to actually get anything or connect with anything. And, that causes a lot of problems because, we are relational beings. And so, I'm sure everyone's seen the still face experiment.
Yes.
And child gets extremely distressed when there's no, what's the word that I'm looking for?
There's no
feedback. There's no feedback as to what's happening. Exactly. And so if you have somebody that is walking around with a completely, pan-faced look, it's very difficult for people to trust them because they don't know what is going on if they're not a bad person. And so that causes a lot of problems in interpersonal relationships, isolation, obviously. And then there's like, it just kind of compounds the beliefs that I don't fit in or people don't like me or
absolutely. Yeah. So it really becomes like a disability socially, doesn't it? And
for sure.
Yeah. And it unfortunately reinforces itself because people feel very uncomfortable around you. So that's so helpful. And I think for me, it's given me a much better sense of what I might be looking for just generally and the sorts of people that these two schemas are going to fit with.
Did you want me to give you a couple of sort of my own examples of some patients who?
Yeah, good. The more about the actual work it is, the more enjoyable it is, I think.
Because I was thinking beforehand, what might be helpful. So thought about a couple of patients that I see. Yeah. So one patient, when they first presented for treatment, they were like it's his emotional constriction, exactly how I described. Would come in, wouldn't say anything. I'm fine. I'm good. Would find it difficult to open up, even just kind of have regular sort of conversation around things. And for that person, again, a lot of difficulty being able to connect with people, a lot of, fear of other people, a lot of monitoring as well.
Right.
And this person, as it turns out later on, I diagnosed him with ADHD and then he got proper treatment. That was an underlying thing, but the emotional constriction was still a massive problem, right? Because of the relational nature of our existence. And so for him, one of the really important things for us was to introduce into the therapy space a lot of like spontaneity and playfulness, because you'll see with those patients, fun is not in their vocabulary, right? And so for us, it was really creating a space where we could help him feel safe in the therapy space, where he could comfortably start to experience his emotions, where he could start to laugh, and so whenever he'd like smile, be like, right? So
and was this a person who was deprived of play in childhood?
Yeah, so if you go back to the origins of this person, lots of over control, parenting, fearful of the world a little bit as well.
Okay.
But parents were very big, took up a lot of room, right? And so when that kind of happens, as I mentioned before, then, and also very reactionary. So it kind of touches in a little bit with what you had mentioned before. So when people are big, people want to be small or hide because it's safer.
Yes.
But also for him, his emotions were completely invalidated. They were shut down or ridiculed. And so, so that was then the platform. And then, obviously that continues to school, and he has problems with, connecting with buddies and making friends, and then bullying. And it's just
the trajectory that happens. And that's a really beautiful example. And I think so great to hear that play was the way in here.
Absolutely. I think that's underrated. Like, being able to just be authentic in the therapy space and have, really try and open up the space so there's a real genuine kind of connection there. Is critical, and that includes being spontaneous and playful, because that also goes hand in hand with curiosity and exploration. And when patients start to do that and they feel safer doing that, then the gains start to mount up.
Sounds like some really beautiful work. Thank you for sharing that. And what about your other example?
So we're going to talk about fear of losing control. So a patient who was referred for pretty chronic OCD, and she was extremely self-monitoring. And then there were also a whole plethora of other difficulties there that needed, I guess, addressing at the same time. But this person had a lot of impulsivity historically as well that had got them into trouble. Lots of intrusions about, well, you can leave that to your imagination, but, essentially harming people, sexually assaulting somebody.
This is the stuff that we see in the sexual and harm obsession stuff. It's quite severe, and that's why it's so horrific for people to experience.
Yeah, absolutely. It's, I don't love when, OCD is, or ADHD and stuff like a downplayed. You've got so OCD, but it's actually really chronic and debilitating for a lot of people.
And then, people are walking around with just horrific images appearing in their head and worrying about, themselves as a safe person. And
exactly.
And so what happened with this one?
Well, I guess it was about identifying a bunch of that stuff first. So, and that took a little while because, those awful things are not easy to talk about. And so for her it was more about building a relationship, having a bit more of an emphasis on helping her feel that her emotions and her behaviors were not going to get out of control. Right. If she talked about them, or if she was able to, express them, or if we were going to process them. This stuff can be really treatment interfering. I'll talk about that in a sec, but so, for her, it was about distress tolerance. It was about experiential techniques around helping her feel safe and getting a sense of control in spaces where she otherwise might not have interpersonal space, or, where there's perceived environmental threat when there isn't. And that worked very hard, long-term patient. So that's kind of was some of the things we did for her. Also for going back to the other fellow, that was, around, also radically open DBT.
I have not done a training on that, but I have heard of it, yes.
Really good for emotionally constricted patients.
Okay.
Really, really good. And we also, for both of them, did lots of imagery stuff, but different in different ways. So for him, it was around like the early experiences of shame, first experienced shame, and for her, it was about like when something had happened when she'd been, when she had control of herself or was impulsive or so does that answer? Is that enough? Is that enough example?
I could talk about it all day, but I think that's really lovely examples, and I can just hear how flexibly you're working. And one thing I know there's a set way of doing schema therapy, but I always talk to people about it's really about meeting the need, and the need is different between people. So some of our clients are going to need more of the exposure and the behavioural stuff. Some of them are going to need more support to play, and we can provide limiting reparenting to varying degrees as well based on that need. So it's been really useful to hear about that.
Yeah, EMDR and schema therapy are like a hand in glove. I think if anyone is a schema therapist, they should, I would encourage them, if they haven't already done, but get trained in EMDR. Like I'm about to become a consultant, very close. So, and since having, we've essentially learnt schema therapy and EMDR at the same time, and that's why I love it. But it's so integrative. It can really help with, shifting this kind of stuff. Yeah. If you're trying to do trauma treatment, trying to process a trauma with an alexithymic person or a really emotionally constricted person is almost impossible, because you need to have some level of activation.
Yeah.
And so actually first it might be, if you're running into challenges, that might actually be one of the blocks or one of the barriers. So it might be worth going back, helping this person become more connected so that, all of those parts can be activated in order to be able to process.
Yeah. So this isn't an EMDR group, but I'm going to say it anyway. So, in EMDR therapy, we would see that as part of that phase 2, that resourcing and getting them ready to be able to do that. And although chemotherapy is its own complete treatment, a lot of the ways of conceptualizing people around connection and attachment can be really beautiful for that part.
For sure.
You can do that.
And even if like you're not EMDR trained, at least get really good training in imagery rescripting, and imagery rescripting is a part of schema therapy. And so even the research, I think one of my colleagues, she did, EMDR versus imagery rescripting, they're both pretty equal. So
absolutely.
I think, be really good to Katrina.
They're both, Bodehoven and Denhart, I think, yes. But they're both sort of working with the same sort of idea of trying to reprocess the memory and create an adaptive learning, and it just comes at it from different ways. So yes, I think we both bat for the same team there in terms of the combination of those two. So before we conclude the interview, some group members did ask some questions that they wanted me to, and I thought, seeing as we have you here, I'll ask you. The first one was just a bit about the online version. It spits out a bit of a different score analysis from the original Excel. So I think when I was looking at it today, it's doing a percentage of the 5s and 6 down a little column, whereas in the past we would get little mean graphs and stuff like that. So is there any chance that's going to change, was the question?
Well, actually it doesn't need to, because the graph is the mean scores. The percentages of 5s or 6s are just the percentages of 5s or 6s. So when I was talking with, when I was working with Jason on this,
right.
The graph itself is our mean scores.
So and the little graph on the first page before you see. Yeah. And I think the other thing is that I like is it's very easy to see all the item scores next to that percentage thing. So how sometimes you're like, how did they get that? And then you can go, they put a 6 next to this one and that. Whereas in the old way, it was very hard to have everything sort of different screens. And so I like it. But anyway, that was just a question.
Then we were just going to leave it at that. But then afterwards, I was like, well, actually, you have those patients, those are the borderline patients and things like that are going to score really high on everything. And so then how do you find the nuanced schemas? And you need the percentages of 5s or 6s to be able to do that, to be able to identify that. And that was the reason why I included that in all of the versions now. So I've updated the YSQ-R Excel version. It's 4.3 now. And there's also an updated Excel questionnaire version. I've also updated the introductory guide to schema therapy. So I don't know, do you want me to put those somewhere?
I think you already have.
I'll have a look.
I've got them. Yeah, I think we've got all the modern version.
Yeah, and so sometimes
not modern. I mean, it's all very modern. It's all up to date now. So thank you for that. And the next question is, why were the questions put in schemas order and not randomly? And I think that's because a lot of questionnaires, they do that. They sort of jumble things up and clients don't get a run of a certain thing.
Yeah, good question. So, like I said, the long form, there hadn't been a whole bunch of research on that. And the short form is random. That's how it's administered. The long form is not. So originally, the long form has always been like that. And so, in an attempt to be consistent with that way of administering it, that's how I left it. That's not to say that that's the best way, by the way, but I just haven't done any studies or any research that compares, say, the YSQ-R with a long form or something like that. However, my colleague and friend Vicky did do a study on this, comparing the two short forms in blocked or random.
Yes.
And I've forgotten what she found.
Well, if you're interested, you can look up Vicky's study, everybody.
Yeah, or I can send a link or so. I can find it and send it over. So hopefully that'll answer it. But that was the rationale why we continue to do it in a block.
Yeah. For me as a therapist, I prefer having it all in a block. I think there's something about, particularly when I was trying to look at items and I'd have to be looking for those little codes on the site. Anyway.
I also find that annoying. So I agree with you.
That's probably just a personality preference thing, not a science thing. Anyway, the final question from the group, and I'm going to read this out because it's a bit of in the article, which I think must be something that you've published, it is said that the YSQ-R retained excellent reliability across all subscales except for the enmeshment subscale and further emotional inhibition and punitiveness. The changes that were suggested to the last two schemas are very clear, but what about enmeshment? Any comments about the enmeshment schema regarding your findings?
Thank you. That's a good question. So what happened? I guess there's a couple of things to that. So we essentially, let me think about this. That is a long question. Do you let me just try and find.
Well, what if we just shortened it to, for the purpose of today?
Yeah, please.
What are we doing about the enmeshment schema?
Okay. What are we doing about it? Well, nothing at the moment, because in my third paper, so that was in the second paper, in the third paper, which did the predictive validity, I didn't see those kind of similar issues didn't come up in that. That doesn't mean that there's not an issue with it. But one of the things, I guess, when you think about that enmeshment schema is in a clinical population, you might expect, obviously, that to be different to the general population. So I had reasonably large general population and even bigger clinical population. Just trying to think about what the finding was for both. Maybe I can make a more general remark around this is, even for some of the other schemas, I think some of the items could be better worded.
Yes.
And I think there could be some items added to some of the schemas, because we've shortened it as much as possible now. But I think adding some items that might be pertinent would be beneficial, including to maybe enmeshment and also fear of losing control. That could probably do with another item or two. I was reluctant to add anything or change any of the wording on any of them because this question was obviously originally created by Dr. Jeffrey Young, and I didn't want to muck around with any of the way that things were written. And so
that was that one,
so maybe in future research, which I'm looking at now, looking at the schema domains in the YSQ-R.
Yes.
And this is obviously one of the other things that I've got on the list to look at in more detail. So sorry, I didn't probably answer the question.
And I just as I mentioned, I'm a little bit clueless on the research side of things. But when I think about enmeshment and then / undeveloped self, there's like these two dimensions to it, and not all clients resonate with both. So, for example, I myself had that schema, but I wouldn't have related to the super closeness aspect because that's not how it was operating for me. So I think that's part of where the questions don't always so much work on that thing. And in fact, I wouldn't have even I wouldn't have endorsed any of them. But, I have it. So I think it's healed. Fingers crossed.
Good. Awesome. Yeah.
All right. So what is next for you? I mean, you've mentioned lots of things you're still researching, which is really quite unusual for people who are running practices, developing clinicians to also still have a toe in research. So is there anything else, any trainings or webinars? I know sometimes you do stuff about BPD and ADHD, which is quite topical and interesting.
Oh, thanks. Yeah. Actually, adult ADHD is a passion area of mine. I mean, I myself was diagnosed about 3 years ago. I actually have a podcast that I did. It's called Demystifying Adult ADHD, where I talk about how ADHD actually presents clinically in session as opposed to sort of what you might find in the diagnostic criteria and, and some of the lived experience stuff. And that includes kind of, I guess, breaking down stigma as a clinician in terms of help seeking and things like that, because, it took me a long time to, have the courage to, ask one of my colleagues for an assessment because of, being feared as an impaired practitioner or something or another. And, yes, the ADHD and emotion dysregulation disorders at BPD, I've done a couple of talks on that, and I think, and I'm really passionate about that as well, at my practice. And more generally, I think it's really important to be diagnostically astute for these reasons. Like, we want to know what you're treating, making sure that you've got the right approach for, the appropriate diagnosis. And so, so I think, those kind of, I'll probably doing a bit more in that space, I think.
Great. Well, I'm still upset that I missed the Clean College talk that happened here because it was at the same time as the Enlight conference on that topic. But if you can send me a link to that podcast episode, we can put that in the notes.
Sure.
It's recording, and I'm sure people will want to listen to it, and that's great. So thank you so much for your time today. It's just been my pleasure. We do bump into each other at events, but we never really get this much time to talk, so that's been nice. And I'm sure everyone in the group's going to appreciate getting that more in-depth and more clinical view of what emotional constriction and fear of losing control are. So we'll just say goodbye to the group for now. So if you want to say
thanks so much, Nadine. Thanks, everybody.
And then we'll just have a quick chat before then. Bye, everyone.
Thanks. Bye.